I'll start.
Sure.
This one is, are you using Sudbury vertigo risk score in your practice? So this has been a very hot topic. There's this, was it last year that the paper came out on Sudbury risk score? It wasn't that long ago. There's this new risk score for a diagnosis we all hate, which is differentiating peripheral versus central vertigo. And these Canadian researchers, Sudbury's in Canada, right?
Sudbury is the nickel capital of Canada.
Oh,
They have
really?
a giant nickel right there, and it's a huge nickel mine, yeah.
And so they developed this risk score where you get points for certain things, risk factors, and then some neuro exam stuff. I'm just from memory. And then like if you think it's BPPV, it's like -5 points. And so it's a very attractive thing for those of us who are looking for something to help us, risk stratify and determine what the workup should be. Interestingly, as part of I work as a podcaster on MRAP, which I get no money for promoting, but they in Corpendium, which is a product of MRAP, there's been a bit of discussion about whether to include this in the calculator on Corpendium because so many people had asking about it. And when they reviewed it, like Dr. Matu and Stuart Swadron and smart people, smarter than me, they basically were like, this thing isn't validated yet, so we're not really like confident enough to put this. We don't want to endorse it as like you should be using it when it hasn't been like properly externally validated yet.
Yeah, and I was just checking to see if it was on MD Calc because, how far along is this? And it's not even an MD Calc yet. At least I can't find it. So
that's the reason why it's not there. It doesn't mean that it won't eventually be there, but I think the last paper I read on it, or a commentary from the authors, were that they are working on a validation study with multi-center and different populations of people of their Sudbury risk score. So I think the answer is it's not ready for prime time yet, as determined by lots of people who've looked at it, because it hasn't been yet externally validated to the degree that you could really incorporate it. But it's worth knowing about because I think it looks pretty promising. Their data was very good. There were some criticisms of their early data. Not enough people got MRIs. There were some questions about, are we missing some cases with this derivation set? But putting that aside, I'm sure hopefully in their validation design, they'll address some of those things. We'll see.
my Bayesian approach, and not to be a nihilist and say nothing will work, but most clinical decision instruments don't survive and get past, external validation. And if they do get past external validation, they don't do an impact analysis to actually see if it improves care and outcome. And most clinical decision instruments, when you do the derivation set and you do the validation set where you work, that's where the champions are, and it has great numbers. When they go to external validation, typically the diagnostic accuracy is not as good as where it was done. So,
especially for a complicated thing like a
and
vertigo.
it's not an ankle fracture.
Yeah.
It's the brain and it's complicated. And so, while I wish them well, because Canada, I'm skeptical.
Yeah.
Very much so. I'm going to ask this question regarding corneal abrasions and topicals. I recently had a corneal abrasion, saw an ophthalmologist, a Band-Aid contact, soft extended where a contact lens was placed.
Yep.
It was a miracle. Pain-free, wore for 1 week, then removed. Is this a possible option for ED use?
So I don't know if it's a possible option for ED use because when we were doing the guideline, we were aware of this, but an ophthalmologist has to put it on and an ophthalmologist has to take it off. And so I don't know if if they're not happy with how we're driving the slit lamp and that kind of stuff, if we're going to have be doing that. And I don't think the availability in the acute phase for them to put it on and take it off for most of us have access to ophthalmology in that timely fashion. So I don't know.
They're not going to trust us
I don't
with
know.
that advanced technology.
They can't trust us.
I don't know would be the fair statement, but steel man.
How long does it stay on?
It looks like 1 week.
Yeah, that's a long time for a simple corneal abrasion from my perspective, because, I've had many corneal abrasions, many injuries, but many corneal abrasions, and boy, if they're not better in 1 to 2 days,
Yeah.
I don't need anything after 1 to 2 days.
Right.
But I think the best trial, this is my facetious thing, but the best trial for determining, efficacy and safety and having arguments from authoritative figures like ophthalmologists and emergency physicians would be to take a random sample of ophthalmologists and, take a sample, not random, but of ophthalmologists and emergency physicians and induce, and there's some limitations, but a surgical kind of corneal abrasion just for cleanliness and stuff, and then put the topical anesthetic there. See who goes for it. I'd use it.
Yeah.
Yeah, like absolutely. These things hurt
Yeah,
a lot.
for sure.
I'd use it.
I'd be open to the soft Band-Aid
Yeah, no,
situation.
sure. Yeah,
Yeah.
no, it's a very good treatment for this. Yeah.
Yeah.
This is about thrombolytics. If thrombolytics have such a high risk versus benefits ratio, why are we still doing them, and what can we do to address this on a system level? I'm going to try to keep this relatively short. I think we have made some headway with, we've been talking about the non-disabling strokes. We no longer are obligated to thrombolyse the patients within that 4.5-hour window. Barring any new evidence, even though the evidence isn't great from the original 13 trials, barring any new evidence, RCTs on 0 to 4.5 hours, I don't think it's going to be easy to combat this. From a medical legal standpoint particularly, I think we have to continue to offer it. There's a 2025 JAMA paper talking about updates in the medical malpractice, sort of like some updates in MedMal. The American Law Institute put out a new update that we should really be shifting from the traditional standards of care to evidence-based guideline standards of care and patient-centeredness. And when the part that I thought it was going to, if they had said evidence-based medicine, it would have been great, but they specifically wrote evidence-based guidelines. And the guidelines all tell us that we should be offering TPA. And I think for the foreseeable future, I'm going to continue to offer TPA in the 0 to 4.5 window for patients that have they're not in that non-disabling stroke category, but do some shared decision-making around it and talk about the risk-benefit profile.
Yeah. The horse is out of the barn.
It's hard to put it back in, hard to put the toothpaste back into the tube. But, I think as the technology gets better as well with regards to thrombectomies, we saw that happen with cardiology. We're not lysing as many STEMIs anymore, are we? We're taking them to the cath lab. And so, as the technology gets better, that may be the same path we'll walk, and we'll go, geez, they were arguing about that for a long time, and we don't lyse anymore because we've got something better.
That's possible.
So
or
that
maybe,
is a possible outcome.
Maybe it will be that MRI technology gets better,
perfusion
and we can get better imaging to figure out who actually is, a better candidate, better information than we have right now. All we have right now is, the non-con CT, and then some other data if we even have a chance to have it. But what if you could do an MRI really, really quickly and know up front that they didn't have a stroke? Then we would be at least avoiding it in the people who have stroke mimics. And maybe there's other characteristics we'd learn about to tailor our use. So maybe technology will help us in this area as well. Mine says, how often do you find that your choice of an analgesic is dictated by your department's nursing policies? For example, in my ED, nurses can't give IV fentanyl unless the patient's on a bed. So with our severe ED overcrowding, IV fentanyl is out of the question for more than half of our patients. It's a great point. Not only do I find that my choice of analgesic is dictated by nursing policy, but it's also dictated by nursing staffing levels as well, in the sense that, if I have everybody in the front, if I'm doing my triage shift, and I have a glom of patients out there, and I have 2 or 3 nurses, then I'm very limited in what I can offer in terms of analgesics. I can really only offer oral things or an IM, ketorolac type of analgesic. And if I wanted to give them IV opioids, then I have to move them to a different part of the ER, which then overburdens that area. So yes, I sympathize with this very much. We also have nursing policies that our nurses can't push IV haloperidol like the doctors are supposed to do it. Some of them will do it because they've been doing it for a long time. Some of them who are very policy dependent say, I can't push this unless you do it, or I won't do it without the EKG, and you're okay. And there's those kind of policies. So it depends on the nurse and how they interpret the policy and what their practice is. But I do find that my choice of analgesic is dependent on that. Now, that being said, I will not make the choice that's in the patient's worst interest to not give them IV opioids when I think they need them. So in that case where I really see someone in excruciating pain and I think what they need is IV opioids, then I am going to move that person to the right area to get the right treatment. But certainly the nursing things do have to do with my analgesic choice.
Speaking of opioids, one of the attendees, because we're not reading names, are we?
No.
Asks about oral opioids for kids with acute pain, and they give an example of a fracture, and what are the choices and dosages. And, I'll speak to the IV. For opioids, morphine is 0.05 to 0.1 milligram per kilogram IV, and And then for fentanyl, is it 1 microgram per kilogram, I think? I'm not sure, but that's IV. I'm not sure what the intranasal, I wish I had Sergei Motov sitting right here to whisper in my ear, Ken, this is what the intranasal fentanyl is, because that's another option for giving an opioid. And there's been a number of studies that have come out recently on intranasal fentanyl.
Yeah.
Pediastat's also a great resource. I have no affiliation with it. It was the best $6 I've ever spent in my career, and it allows you to offload some of those numbers, especially when you're dealing with medications for children, right? And getting the weight right and getting the dose right, and is it the right
Pedistat.
medicine? Yeah, so Pedistat is wonderful for anyone who hasn't used it before, and it's really helpful. So you can look it up and see intranasal versus IV, what's the dose, and where you want to start with it, depending on what you're doing to treat them.
And so I have it right here, and so I pulled it up.
Excellent.
Awesome, 1 to 2 micrograms per kilogram.
Exactly.
If it was worth knowing, you'd know it, Ken, but yeah. Yeah, so I use that all the time. I would have to look up hydromorphone, which I just did. And so it gives 0.01 for infants less than a year, milligrams per kilogram. So Pedistat.
I would love a Jerry stat.
A Jerry stat?
Yeah. If anyone's out there listening, Jerry stat, that would
Jerry
be
stat.
wonderful. Because that leads into this
It would just say, don't give them any. Or the Beers criteria.
one page. Since we're starting to get away from narcotics, i.e. Norco, Tylenol 3, what is the best treatment for acute on chronic pain management of an adult elderly patient with acute on chronic pain on blood thinners for whom Tylenol doesn't work? This is a tough one, right? And I think it really matters what are you treating, number one, and then that'll tell you a little bit more. Is it an MSK type pain? Is it back pain? I try sometimes, lidocaine patches, and that sometimes provides relief for patients. You're stuck in this patient population, right? And talking to them, will one tablet of ibuprofen impact them? Likely not. If they use it for a very short period of time, lowest dose possible for that acute phase, I have instructed them that they could potentially take it, but I would take the very lowest amount. So 200 to 400 milligrams, and just take that as if they actually need it for breakthrough pain for the Tylenol. Because there's so much research that suggests that the Tylenol and Motrin, if you take it on schedule, actually does help with the pain. So sometimes they just need a little bit to be able to get them through, but it's hard, and that's more like MSK pain. And then you can try to give them some stretches and things like that they could do if that's the back pain. I don't know if you guys have other suggestions.
I mean, I would first say check to make sure the acetaminophen they're taking is the proper dose,
Right.
that they're taking like an adequate dose for
Yeah,
adults,
yeah,
because
yeah.
a lot of people underdose it for themselves, and so make sure that they're at where they should be. This is why some people use tramadol, because they feel cornered and they're looking for something that's not an NSAID, it's not acetaminophen, but it's not a full opioid, and so they pick tramadol. It's not a great choice, but that's that's one of the justifications that people will give. If it's neuropathic pain, gabapentin, is an option. So thinking about, is it neuropathic pain? What type of pain is it? I think topicals are a good option as well. Yeah.
And then if it's a joint related non-medication, so splinting, if it's a flare up of some joint that's flared up, moving that joint hurts. Splinting joints can be an effective analgesic.
Yeah.
And then you get into joint injections with various things as well, with various efficacy.
And then ice is kind of a nice, like things like that are non-medication.
Ice.
related.
Gate theory of pain, right? Like
Yeah.
the gate theory of pain through the spinal thalamic system. Pain is registered through the same thing as temperature. So, that must be very cold.
Yeah.
It's not my elbow that's hurting, and it's very warm or very cold.
Right.
Yeah.
Ice and heat, they work.
Comment.
Right? Go ahead.
I actually had it in my head that I wanted to say it, but because this is an evidence-based conference, that we don't have great evidence for it.
Can you repeat it?
And then-
Yeah, so the question was about THC cream or CBD cream, cannabinoid cream.
Yeah.
Right.
Edibles, whatever.
Yeah.
So we don't have high quality, like my answer to these types of questions is I'm not aware of any high quality evidence of efficacy. That doesn't mean it doesn't work.
Right.
That's not making the positive claim. That's just not accepting the claim that it does work. And so again, you engage with patients, and pain is so subjective and contextual that having an empathetic clinician and then talking about various things can go a long way, right? And so would I say, don't use it and how dare you use it? No. But some people say that uses it. But is it actually working? I don't know.
And I preface it with that too, that, anecdotally, there are folks that say that it helps. Like I've had people with, neck pain or neck strains and things that think it's amazing, but that's anecdotal and it's not population based. And so I don't put it on my prescription, but sometimes if a patient is out of options, I say, hey, look, there's not a whole lot of evidence behind this, but if you're feeling like you're running out of options, here's a potential thing, depending on the.
I'd let them bring it up, though. I wouldn't bring it up as
I
a
agree with
potential
that.
option.
Yeah.
I would let them bring it up because I'm not aware that there is any good evidence to support that position. But I'd discuss it with them if they brought it up.
Yeah, I think that's a good question. I have a pain management one, so since we're on that theme, do you use the sphenopalatine ganglion block for headache treatment in the ED, and also an occipital nerve block? And so the sphenopalatine ganglion block is when you put the lidocaine jelly or something on the end of a swab, and you go back in the back and you swab back there, and it's theoretically a treatment for resistant headaches that can get some people some good relief. And I've heard that. I haven't tried it a lot myself because I usually find that my initial attempts work pretty well. So I haven't actually ended up doing this, but I do have colleagues in our group, we've talked about this, who really like it and then swear by it for people who are really, struggling with pain management of their migraines, et cetera. So I personally haven't used it a lot. I'm open to it. The evidence to support its use is out there. It's not great evidence. It's a lot of people who say, we tried it versus it, and so it looks pretty good.
Ricky likes it.
It's sort of we liked it type of evidence, but it's really out there. Now, I will say the occipital nerve block I really like. I saw a lady, it's funny that this question was asked. I just saw a lady last week where the resident came and presented. She's like, there's this lady and she's got this pain back here and it's really point tender right there, but I don't see any redness and I don't feel any bumps. Her ear looks fine. She doesn't have a fever, all these things. And I went, it's just that. It was just very point tenderness right at sort of her occipital point in the back, and there was no lump and there was no redness. There was nothing. We're like, why don't we just inject this with a little bit of local lidocaine and see if it helps? And it completely resolved her pain. So sometimes if you can find the right spot, these kinds of local injections can be really effective, I think, in my anecdotal experience. And again, there's little papers here and there for these different types of blocks that are not great. So, these can be helpful in the right circumstance. How about you guys?
Our residents love when new things come out. And so the sphenopalatine one was one that I was like, okay, I don't see a downside to it. And so we will try it occasionally and people like it. And it decreases their length of stay in the ED. I don't have to put an IV or give them a bunch of medications. It's not my go-to every single time, but it's sometimes, right? The ones that come in frequently, and then you don't have to worry about them not being able to drive. And it's not bad. But again, the evidence isn't there, and it's not my number one, but it's something to have in my toolbox that I know I can use.
It would have been great during COVID that you could just put a little lidocaine for everybody that you're swabbing, COVID with headache. Swab them and get rid of the headache at the same time. Yeah. But I know, there has been, for cluster headaches, I know it's been described to work. There's more evidence for cluster headaches. I think there's less on the types of headaches we tend to see in the ED. But I have a question regarding the ACEP protocol with droperidol and benzo use. Was there any mention of use with methamphetamine intoxication?
No. There wasn't anything specific on whether or not to. So they were doing, they took a bunch of studies that had all done it and then compared them together and put the data out there, and so looked at it. So I didn't evaluate every single study that was included in the ACEP clinical policy, but there wasn't anything in the actual clinical policy itself to make any sort of comment on whether there were methamphetamines on board or not. Is that, I think, the answer to the question? Yeah. So I don't know if in the individual studies that were included, there were several. I think there were 10 to 20 different studies that were put in there. I don't know if they had individual level data to say whether there were methamphetamines on board.
Is immediate lidocaine better for ventricular dysrhythmia than waiting for amiodarone?
Oops.
I disagree with the premise.
Use your words, Ken. Tell us more.
I'm not sure we have good evidence that either are great. So,
Well, which one would you pick?
Probably wouldn't pick either.
What would you do?
Shock?
Yeah, electricity. Yeah.
I mean, that's the level at one end.
You know, and then they've looked at shock-resistant dysrhythmias, ventricular dysrhythmias, and I think that was the ALPS trial from 2016, looking at lidocaine versus amiodarone, and they didn't find a statistical difference. Now, they didn't have a placebo arm either, so I'm not. I know it's in the ACLS guidelines for amio, but I'm not. It's not based on really strong evidence for amio.
What if you get a patient that tells you, I don't want to be shocked?
I don't want to be shocked?
Yeah.
Does anyone say they want to be shocked?
Well, if you have a ventricular...
If you're stable.
Yeah, I've had patients that you're stable, and
Yeah.
they have like a ventricular tachycardia, and they're in VTAC, and they're
Stable
persistently in VTAC, there are people that prefer not to be shocked. I've convinced people to get shocked, but, with amio or lido...
Yeah. I think, amio is the guideline answer to
Yeah,
that
no,
question.
amio is the guideline answer, yep.
Yeah.
And the answer on the test.
Yeah.
That doesn't mean it's the right answer. It means it's the answer for the test.
You have to wait longer for it. Yeah.
Is that whether you have to wait longer for the amio to work or to get it from the nurses? To get it from the nurses, the lateral.
Interesting.
The latter, sorry, yeah, because lidocaine's more readily available. Yeah, and I grew up in an era for, a lot of these arrests, it was shock, little shock, right, was lidocaine, big shock, petroleum, mega shock, magnesium, right, shock, little, that was the little thing, and now what's in the old toolbox? Not much, except electricity and diesel fuel.
Gasoline.
For out-of-hospital cardiac arrest, but electricity, I think, is usually the most successful, but not always.
Would it make sense to start at a lower dose instead of a high dose ketamine pre-hospital and just administer it in incremental fashion to possibly negate intubation? So when we looked at the one study with the 60 pre-hospital ketamine, the 250 milligram doses, we didn't see that it was dose dependent that someone needed to be intubated. It wasn't even dose dependent, and you added on benzodiazepines that they needed to be intubated. So I don't know that we know the factor that causes folks to have to be intubated, at least not based on those 60. So I don't know. Sure, but a lot of times when they're being given ketamine, it's an IM injection if you're using it for combative patients and you're trying to sedate them, right? So it's not like where you can start an IV and then give them like a nice doses and reassess them. So I think, at least in certain situations, that it's probably I don't know. There was one study, I think, Ken, that you had gone over where they were giving the ketamine and the morphine doses. Was that it? And they were giving the small doses. And then depending on how long your transport time was, you could end up severely underdosing somebody.
Yeah. Morphine Q5.
Is this ketamine for agitation?
I think so, because that was the one that we had discussed. And if you want to clarify whether it was for agitation or not, you're welcome to. But I think
I think that's the only use of ketamine in pre-hospital that's really being discussed. No one's talking about using ketamine for a pain control in the pre-hospital. It's mostly about agitation. If you're talking about ketamine and agitation, you're either dissociating them or you're not. You're not really sort of incrementally trying the ketamine, to your point, like not for just practical reasons, but just pharmacologic reasons that, the whole point of ketamine in severe agitation is to basically like take them out, like in terms of the connection of their behavior and their motor function. And it's a really nice option for severe agitation, actually. But I want to go full dose dissociation. Let's take them down for their own safety.
Well, we're not doing self-dissociative doses, no.
Yeah, exactly.
Yeah.
That's what I mean.
Yeah.
So therefore, what do you got, Raman?
I have, how might you suggest incorporating a system-wide MOUD or naloxone prescription as a harm reduction technique in a small ER? So, it's a good question. So, in our state, in California, we have a bridge program and we have grant programs that help facilitate the use of medication-assisted treatment and BUP and all of that. And I suppose this would be state-specific. I don't know of any federal grants for it, but there's almost everywhere that right now there is some access to care through grant funding, and I would just look at state-funded or state grants or state facilitated MAT programs and see what pops up.
Yeah, I mean, this is all, this is a very systems-based question. And so kind of what happens in your local, community is a big issue. So like maybe talk to your family practitioners and your other PCPs to see what they're doing for their patients. Maybe there are resources you're not aware of, but I agree that like the whole question is I can do it, but like what else do they get after me? And that's a pretty open question. I'll bet we're not going to see a lot of federal investment in this particular type of thing going forward, but who knows?
One thing to note about it is it can be one person who's super passionate about it that can change the culture when it comes to this, but it is a lot of your time that you're going to be investing into it. You're going to go meet with people in the outpatient setting. The Bridge program is fantastic and has a ton of resources online for you for how you can even have those discussions, what you really need, like a navigator at your site, and being able to get folks on the outside who are going to follow up with these patients. So there's a lot on the Bridge website or that can help you kind of guide through that. But if you're truly passionate about doing this, it just takes a few folks that are really passionate to put that time and effort into it, and you can make a big change in your community, especially small communities.
Yeah, that's true.
Bridge, California Bridge, BRIDGE.
Yeah. It was started up at Alameda Hospital or Highland Hospital up in Oakland by Andrew Herring and their group up there. And it is an online resource that's just like got all the information you need about doses and how to give it and patient instructions and all kinds of resources.
You don't need to start from scratch with what they have on there. It's really fantastic.
Yeah. Thoughts on giving pocket prescriptions for an antibiotic to prevent patient bounce back rates. So the idea of you might need antibiotics. I don't think you do right now, but maybe you will, but I'll write you the script so that you can maybe start taking them under these conditions so that you don't have to come back and get it. This sort of watch and wait or delayed prescription strategy. And that's been something that's been proposed to help us reduce antibiotic utilization rates because maybe we can avoid some people taking antibiotics for viral infections if we did something like this. I think that this has been shown to be a strategy that's one way in terms of antibiotic stewardship, to decrease antibiotic usage rates and still meet some patient satisfaction metrics, sort of meet them halfway and sort of this type of thing. Do I do this? Yeah, I do it sometimes. I do this sometimes. I think that, for the person who's really pushing you for antibiotics and you really don't think that they're indicated, one compromise is to explain why you don't think they're indicated, but I'll give you the prescription and under these conditions, in a couple days, if your fever is this, you could take it. How many of those people go out and actually fill the prescription right now, despite this whole conversation I have? There's been some papers looking at it. It's not 100%. No. Some people will wait and actually never fill that prescription. So there is some wins there. You may have some losses, but there are some W's in that category. So that is one strategy. What do you think, Ken?
It's not a standard part of my practice to give watch and wait prescriptions, but I do it? Yes.
Yeah.
So if I have somebody who's early on in an illness and it's going to be too early to tell and they're flying out to a destination wedding, here's your prescription.
Yeah.
Again, that's where you're talking about your patient's values and expectations, because there may be these blurry zones where, is it the hill I'm going to die on? No, but I'm not going to every patient. I'm not sure, so here. If I'm not sure, I'm not prescribing.
Correct.
If I'm not convinced that the potential benefits outweigh the potential harms, then I'm not prescribing. And I'm trying not to use that as I'm worried that if I do the watch and wait, that I'll expand the number of prescriptions I write. Because I'll go, well, I could always do this. Mm-hmm. But boy, for that person that's like traveling or going off to, something where they're going to be leaving the healthcare system or something like that, then I have no problem with it.
All right, I think we have time for this last question because it leads us into trauma part 3, which we'll do right after it. Do you have any recommendation strategies for actually implementing teletrauma in rural ERs? And Ken, how would you recommend selling this to administration? If you guys want to reprise your roles.
Great question.
No, we only have 40 seconds left. The lightning can't strike twice. There are systems already set up for teletrauma where I work, and we have a couple of things. One, in the last year or so, they came out with a program where there is a urban emergency physician on call, ready to answer questions in a non-judgmental fashion and help out a rural physician, usually a family physician, a GP working in a remote or isolated area, and can chat through things. What do you think I should do for this? What do you think I do that? And that's just nice having someone on the other end of the line. For trauma, they actually have, like I work in a place called Kenora, which is up in Lake of the Woods near Winnipeg in a northerner part of Ontario. And they actually have a trauma room with the cameras in the room and like a doc on an iPad face that they move into the room that's from the trauma center that can be there on site virtually and work with you for the trauma. So that's how we've set it up in Ontario, to have those certain nodes around, just like we do for telestroke.
Do you have to do it, or is it a choice? You know what I'm saying? Like, is it part of your protocol, turn it on, like do it, or is it like if you want a consultation, you can ask for it? I'm just curious.
I think it's if you want.
Okay.
I think it's on demand as asked. They're available.
Yeah.
But it's not like every trauma that comes in, because
have to do it.
certainly not every trauma that came in, we were activating it. We were just doing it, and it'd be physician dependent then, right?
Yeah.
But I have used it.
Cool.
All right.